Hi there. It is 3 p.m. Pacific Standard Time, and I am live on my Instagram channel at Faces by DRT. I'm waiting for the rest of my friends to join and some new ones. So I guess Dr. Victor Bichara, very nice to meet you. Jason, I see you. And Radek Tusek. I hope I'm pronouncing that correctly. And my friend Dr. Tina Ho is on an AC bar. Hi, Jason. All right, so I am going to, hi there. Okay, so now I am trying to see if I can get Tina to go on with me. My friend Tina is joining us today, all the way over from Philadelphia. There you are. How are you? Hi. You look great. Hi. God, you clean up so well.
How are you? I'm doing pretty good. How about you?
I am good. Let's see if I can raise up my volume up a little bit because I don't know if I can hear you so well.
Okay, let me see here. Let me try.
Maybe turning up your volume a little bit.
Yeah.
Hi, Dr. Young and Yvonne and Gary, I assume. So this is,
okay.
My name is Dr. Kristina Tansavatdi, and I'm a facial plastic surgeon in Westlake Village, California, which is just north of Malibu and north of Beverly Hills. So I'm a little bit out of that zone. And I have my friend here, Dr. Tina Ho. She is from Philadelphia, Pennsylvania. Is that correct? Why don't you go ahead and give us your introduction?
Okay. Thanks for having me, Kristina. Hi, I'm Tina Ho. I'm a facial plastic surgeon as well, practicing in the Philadelphia area.
Hi, Susan.
Like Kristina, my facial plastic surgeon, specialize in procedures of the face, particularly rhinoplasty and injectables.
Great. Do you think you could go up on your volume just a little bit more?
Okay. Let me see here. Does this sound a little bit better?
Are you on like a Bluetooth?
I am not.
No?
Here.
Are you on a laptop?
I have the volume all the way up. Is this better or no?
Slightly. I don't know if it's me. Can everybody hear me just fine?
Okay, let's see.
Am I loud enough? I hope I'm loud enough. I don't know if it's maybe my phone then.
Let me come in a little bit closer. How about this? Is this a little better?
Yeah.
Okay.
Okay.
Great. Maybe because I was on my ringer on silent, but
yeah.
Okay. And just let me know if you can't hear me too well.
Okay, perfect. All right, so today we have our topic is on rhinoplasty. And yes, so Dr. Young, great. You can hear both of us. That's great.
Great, thank you.
Okay, so tell us a little bit about your practice and your practice on rhinoplasty.
So I trained with one of the top rhinoplasty surgeons in Chicago, have mainly learned open approach as well as closed approach as well. For those of you who don't know kind of the difference between open versus closed approach, open approach basically means there's an additional incision right here in the nose, in addition to incisions that are inside the nose. This approach helps a surgeon be able to lift up the skin, really see the cartilage structures underneath, be able to do more during surgery. Kind of the downsides to doing this surgery can take longer, maybe a little bit more healing, taking longer and swelling in the healing process as well. Closed approach is another popular technique. I would say it's more difficult to master. Basically, the surgeon goes through hidden incisions through the nostrils only to be able to do a rhinoplasty, and it can be more limited in what a rhinoplasty surgeon can do.
So what do you prefer?
So I prefer open approach. I think to me just being a younger surgeon, sometimes it just takes more experience to then be able to take on the closed approach and feel more comfortable with it. Just again, how I trained, where it's really important not only to think about the aesthetic of the nose, but also the structure of the nose to make sure a patient breathes well for the long run. So that really means looking at the cartilage framework, and I think the open approach is best for that.
Great. So for the doctors that joined, which technique do you enjoy doing? So we've just been talking about open and closed rhinoplasty approaches. I guess since I saw a few physicians in the house here, I was going to ask, since I would say about 75 to 80% of my procedures are done open, and then 20% are done closed. I do closed rhinoplasty if the patient is only interested in addressing the bridge of the nose, a bump, any crookedness, and nothing to do with the tip. Then I will focus just on a closed rhinoplasty. But a majority of cases do require some work on the tip, so I do that. So, Dr. Young asks a question right from the beginning here. Do either of you have experience with dorsal preservation or so-called push-down technique? No, I do not have experience with that, but I know what you're talking about, and I've heard some talks about it. What do you want to answer that question? Do you have experience with it?
I would say go ahead. I don't perform that either,
okay. So I know what people will do is they will preserve the bump, actually just taking that down, addressing the bridge, and then bring the whole, basically the roof, bringing it down. So in essence, you're keeping the roof intact to help. I don't know if that necessarily helps with the structure and helps prevent collapse. I would see that might be important to preventing a inverted V deformity. So Dr. Young, do you want to join us on that talk? I don't know if he's here still. So there might be a little time with the response. But anyways, I was going to go on by saying, no, I do not have experience with that. One of the things that I've changed in my technique over the years is I used to do a lot of spreadographs, placement of spreadographs. And now I have turned to doing more of auto spreadographs rather than using spreadographs themselves. I actually like to preserve as much as possible and reuse, so I do not take spreadographs from the septum, but actually bring in the upper lateral cartilages and roll them down. I do not have experience with it, but I find it interesting. I believe our colleagues in Turkey do courses. That's great to know, Dr. Young. I think it's helpful to always learn from our international community, particularly at this time when we are finding ourselves that we live in not just in our own world, but we are more of an international community more than ever. All right, so we do have some other questions and some questions that were posted here. I'm going to bring this up, I guess. Do you want to post a question that you received?
I guess go ahead first. Let me see if we had any questions. Yep.
Sure. Okay. So I have here. Question is, how is a non-surgical rhino performed? Hi, Kaylee. Hi, Halo. You want to answer that?
So non-surgical. I would assume this means, it's either called non-surgical or liquid rhinoplasty. It's a type of procedure where I don't myself routinely perform, but basically an alternative to surgical rhinoplasty, usually involving filler injection. There's pluses and minuses to thinking about non-surgical versus surgical. Something that's really attractive, as this is an increasingly popular procedure, is that it can be done in the office. You can leave right away with some minimal swelling, no downtime, and get immediate results. On the other hand, I think liquid rhinoplasty, there's limitations to it. Only surgical rhinoplasty where you can achieve definitive results, whether it's altering the tip, taking down the bridge, and also in terms of possible risks, it's always important to take into account the most serious risks associated with filler, which include potentially blindness.
Yeah, that's a great way of just, you answered that so succinctly. That was great, about the complications, the risks, and how the procedure is done. I do want to add, for non-surgical rhinoplasty, although I haven't done this technique myself, I do fillers for non-surgical rhinoplasty, but I have seen non-surgical rhinoplasty done with threads. So I don't know if anybody out there has heard of this, but I will describe, I've had two patients, not the ones that I've done, but two patients who've had threads from somewhere else, and these are done more internationally, and they can have their own complications. So threading in the nose, because it's so small and the skin is so thin, one of the areas where it can show pretty well is right on the bridge here. So the thread can be kind of visible because the skin's so thin there. That kind of makes sense, right, Dr. Ho? So the skin is thinnest on the radix.
Are they similar threads?
Was that?
Okay. Are they similar threading like for brow lift and non-surgical facelift?
Yeah, so you can literally see it tented up right along that radix, and they're inserting it here and going all the way to the tip to kind of rotate the tip, so they're lifting the tip that way and also trying to get a little refinement. So you know, I can see where it can be helpful, but because I've already seen two with complications, one who said she had gone so many different places, nobody could answer how to take care of that. So if the thread is visible, then the thing that I did for her was the non-surgical route, which is a non-surgical rhinoplasty. She didn't want the thread removed. She liked how her tip looked. She liked how it raised her tip, so she didn't want to take the thread out. So the technique that I did for her was to take filler and hide the thread. So inject around the thread. Yeah. So literally just using a little volume to hide the thread. The second patient, the thread, we don't know what particular product was the thread, but the thread did extrude. So the skin, it left a hole in the skin, and then it got infected, and it was a very slow wound to heal.
Oh, wow.
High FAMA and high ADON. So our topic today is about rhinoplasty. If you do have questions, please feel free to put in your comment section down below. We're answering questions on both surgical and non-surgical rhinoplasty. Dr. Ho here is a master at surgical rhinoplasty, and I do both. So I'm kind of the person talking about the non-surgical rhinoplasty here today. And if you do have questions, feel free to post them down below. So
I think when you mention infection, that's also definitely a good consideration to take into account. I know I've had patients who ask me, well, I've had filler maybe 3 months ago. When is a good time to think about surgical rhinoplasty? Ideally, you'd want the material to be gone as much as possible to optimize your surgical results. Where I trained in Chicago, my mentor had several cases where he was literally taking out filler, which makes the surgery much more challenging. And also some of these patients were at higher risk for and had complications of infection that he had to take really seriously after surgery.
I do agree with that. Since we are in an age where a lot of people use fillers, it is something that I have to now remember to ask before any surgery. So this is true for both facelift, eyelid surgery, nose surgery, any surgery you get done. One of the things for the crowd who's coming and listening is that if you're thinking of having surgery down the road, if you have had any fillers in the face or in the butts or in anywhere else in the body, you would want that filler removed before you have surgery, because it becomes a problem after surgery because the filler can attract swelling, it can distort the area, and as for surgeons like us, we have difficulty visualizing the end result if there's swelling at the time of surgery from the filler still being in place. So I usually recommend dissolving all of the filler before your surgery. Please remember to tell your surgeon you have filler. Even if it was 5 years ago, it could still be there. All right, so Tweety asks, how soon should I get filler dissolved if I'm considering surgery? What would you say, Dr. Ho?
So it just depends on time frame for surgery. I would highly recommend, if you're thinking about a surgical consultation, get it dissolved sooner than later so that your surgeon can see your baseline anatomy, be able to take more accurate preoperative photos, and set realistic expectations with you. So I would say sooner the better if you're already going down that path of wanting surgery in the near future.
I think it's hard because some patients will want to they don't want to have a period where they have nothing. So that's hard for them to go from having something there and being able to address what was used to be a bump or whatever and having it gone and now going backwards. So what I usually recommend is I have them do it at least 2 to 3 weeks before surgery so we have enough time. Because some fillers like Juvederm require a second or third injection to dissolve all of it because it's so cross-linked. So what I do is we do it at the 2-week mark, we do the pre-op, I do the injection to dissolve, and then I bring them back in a couple of days, and then we assess. If we have to do another injection, we do. So it gives me at least another 2 more follow-ups before the surgery to make sure it's all gone.
Okay. Yeah, that seems like a great plan as well. I see a question from AC Bar. Thank you for your question. Christine, I'm not sure if you'd like to answer this first. How long does it take to dissolve fillers?
Hi there, Deanna. So AC Bar asks, how long does it take to dissolve fillers? Fillers doesn't take that long to dissolve. When we use hyaluronidase, which is the enzyme that most injectors will use to dissolve fillers, the injection takes literally a minute or two to do, and then it takes about 48 hours to dissolve, sometimes even less than that. Most of my patients will say it was overnight, so 24 hours. And then after that period of time, it will dissolve your own natural hyaluronic acid that's in your skin. So you have to be aware of that. It might overdo it and you get a little scared and then your volume comes back a little bit. So that's why I like to give at least a couple days between injections. So I assess after 3 days. That's usually my time frame. What do you do, Dr. Ho?
I totally agree with you. Hi, I think Jay led us to, again, this is Christina and Tina. We're two facial plastic surgeons talking about filler related to non-surgical rhinoplasty. Yes, I tell patients it may take up to 2 to 3 days to see the final results from an injection with hyaluronidase. I do sometimes see very immediate results as soon as minutes after injection as well. But I'm willing to see a patient as soon as 3 days or the next week to do more. Different from when you're putting in filler, it's not as focal and accurate when it comes time of dissolving filler, especially if you want to just take a little bit down. So a lot of times it's nice to just do it stepwise in a conservative fashion.
Right. So again, hi Deanna, hi JC, and PH Nero Webb. All right, so next question I have here that was posted. This is a great one. This actually applies to me too as well. All right, question is, I am an Asian female bothered by my flat bridge and round tip. How can surgery help?
Okay, so I can get started with this.
Yes.
So again, how I trained, I'm all about creating a nice strong structure using cartilage, natural cartilage that patients typically have in their bodies. So my recommendation would be to try to use the cartilage. First, you can try to use inside the nose and the septum to build up the dorsum, the bridge to the nose. Depending on how flat the bridge is, some Asian patients may require cartilage from elsewhere. My second area of choice would be rib cartilage to build up the bridge of the nose. And then for the tip, it requires doing particular suturing refinement techniques to get a more refined tip. I also do take into account the thickness of the skin of a patient. Many Asian patients have thicker skin, so the realistic expectations when it comes to trying to refine a tip is that it won't be as refined compared to a patient with thinner skin, and they need to take into account that they may have more prolonged swelling in the healing period with thicker skin as well. The plus side of thicker skin is that if you are trying to do a lot of cartilage graft suturing techniques, it camouflages pretty nicely. But, for both of us as rhinoplasty specialists, we're trained in certain techniques, certain tip grafts, certain suturing techniques to try to help refine the tip as much as possible.
So I'll talk about the non-surgical technique, I guess, because you talked about the surgical. Let me tell everybody about Asian rhinoplasty and why we're talking about that. So I will show my nose. Hopefully, I don't know if you can see my nose and my low bridge. So a westernized approach to the nose. I mean, one of the downsides of an Asian nose, I feel like I'm beautiful. I like my nose. I'm not suggesting that I'm going to get anything done for my nose. But for those who have an Asian nose, they can sometimes have a very flat bridge. Mine is okay. I've seen much flatter. And so with a flat bridge, we just want to build that up to just have a little bit of refinement of our bridge. Sometimes I will use makeup to highlight the bridge so I can get like sort of a outline or contour. But for those who want a surgical approach is what you just did. And for me, one way I do it for a non-surgical approach is I will use fillers to just build up along the middle of the nose and build that up so that it doesn't look so flat here, and that my when I put my glasses on, it doesn't look like it's pancaked right up on my face. So that's how I would do it with the filler. And then for the tip, I just get a slight refinement, so I'll add a little bit to the tip. I like to think about it in terms of the dome of the nose, like the tip structure underneath the skin. So I do the highlight right on there so that I can get that just to get a little refinement with the filler. And I like to use a very small needle so that's very comfortable for my patients. So it doesn't have to be painful. I know some people will use a cannula, which is a blunt tip, to decrease the risk of getting it injected into a blood vessel. I think that you will always keep having discussions between different doctors, which one is safer, cannula or needle. I think it is dependent on the injector, who is injecting it, what they're comfortable with, and just the proper technique so that you avoid getting injected into the blood vessel. That's the way to avoid that. All right.
What are your products of choice for filler, or does it depend on the situation? What's your product of choice for filler in the nose?
So I like Juvederm, but I don't like it if it's for refinement. So if I'm gonna do it for refinement in the tip of the nose, I typically like a Restylane product to use for that. The problem with Juvederm, particularly on the bridge of the nose, is it can widen the bridge with time because it will attract water, just like it's done in other areas. It will attract water. In the lips, it's great, but then in the bridge, it attracts water and you get this bridge to look wider and wider. So I've seen that with other patients and we've had to dissolve their filler. So I don't like using Juvederm on the bridge. Preferably I use Restylane or Restylane Lift. Those are the two I like. Radiesse is too tricky because you can't dissolve it. So on the bridge of the nose is the only spot I use it for, is Radiesse for an Asian nose that's very flat. Then I'll use Radiesse because it really lifts a lot.
Okay, great. Yeah, thanks for your feedback, Dr. Young. I know we've had a couple more join here.
Hi, Amanda.
Again. I'm Tina. This is Kristina. We're two facial plastic surgeons talking about surgical versus liquid rhinoplasty. Tweety26 had a question. I've heard of others using implants. Do you recommend this? Do you want me to go ahead and answer?
Yeah, go ahead. That's a great question.
Yes. So I previously talked about how I do rhinoplasty, how I train, where I like to use the patient's natural cartilage first in the septum, then second choice is the rib. There are other surgeons out there who use implants. For instance, like MedPore, silicone implants is very popular in Asia. It makes the procedure a lot faster. So it is a very prevalent surgery. It's just based on my training. A lot of it's how we train and then what we learn in experience. I do prefer natural cartilage in that I myself in my training have seen complications associated with implants. They can extrude. I've seen implants come through the skin of the nose. They can become distorted, not stay in the same position. And then just like we were talking about filler earlier, because it's a foreign body in your nose, it's prone to infection. And again, when you undergo rhinoplasty, you're prone to infection as well, but there's different considerations to take into account when you think of placing an implant in the nose. Just my preference is to use your own cartilage.
Hi, Sarah.
For surgical rhinoplasty.
Saxon. Okay.
So how about
Yeah.
you? Have you ever used implants in rhinoplasty, or do
I
you
have
use
never
cartilage?
used implants, and I swear I will never use implants in the nose. I just seen too many get infected and
Right.
having to take them out. They've extruded through the skin. They could be here, they could be at the top of the bridge, they could be through the nose, and it is just so hard to take care of later because now they have scarring. And so I don't use any implants in the nose. I will say that people will come in and say they're worried that it's going to get infected because they'll have sensation of tenderness or pain or warmth that goes up and down. And
Mm-hmm.
in those cases, I usually recommend taking it out as soon as you can and then going through a period where there is no implant. We don't reconstruct right away. What is your thinking? Do you think that you could take out the implant clean and then reconstruct right away, or would you wait?
I think if the cavity looks pretty clean and they don't have a history of a recent infection or any issues, we could potentially do the rhinoplasty at the same time. Also, just where I train in Chicago, again, he's very meticulous. A lot of you would know him by name if I mentioned his name. But there's also certain protocol that we could take after surgery, for instance, using like antibiotic rinses, and other protocol just to really minimize that risk of infection afterward for a history of a foreign body in the
Yeah,
nose, regardless.
right. All right, so we had another question here from AC Bar. Is there a high revision rate for rhinoplasty? Or what is the most common complication do you look for after the procedure?
That's a good question.
What is your revision rate? I get that question all the time. My patients will ask me, what is your revision rate? I usually quote about 5 to 6%, and the highest revision would be from what I see in my practice is if they have a residual bump that happens after surgery. So there are ways to minimize that. I will do some taping after surgery. I will maybe even have them wear the cast a little bit longer. Those are all things that I try to do to mitigate the swelling, because most of the time it's swelling that leads to a residual bump that comes back up. But that's the most common reason why I would do a revision.
Okay.
How about you?
I would just say I'm just, as you can tell, I look young. I'm just still a younger surgeon, so I haven't necessarily taken on revision cases of mine yet. I do have training in revision rhinoplasty. Good question in terms of most common complication. To me, and it goes along with a lot of the aesthetic procedures we do, I would say unsatisfactory result. We've learned when it comes to seeing and counseling potential rhinoplasty patients with the nose, just even a millimeter change makes a big difference
Yeah.
to the surgeon and the patient. And also, some patients might not have as realistic expectations that we can give them with surgery. So as Kristina mentioned, even a little bit of a swelling, I like to give realistic expectations, and I will say your nose is going to swell. In the immediate period, a lot of the swelling goes down within 1 to 2 weeks, maybe up to a month. But you may have subtle changes in swelling. They can flare up
Yeah.
up to months to a year out, maybe even years out.
Right.
And if, for instance, you have thicker skin and you want that refined tip, there's realistic
Hi, Dr. Rob.
expectations there of what can be done
Hi,
or
Ashley.
not done. Or if a patient thinks there's a slight deviation, it
Right.
can be a big deal as
Yeah.
well.
I think it's counseling. That's true for any surgery. It's about counseling the patient beforehand so they know the appropriate expectations. We're not looking for perfection. We're looking for good, right? A good outcome.
Right.
Yeah.
Right.
So this was Christine's question. How do I know if I have a deviated septum?
Okay, so I can start off for a bit. So a lot of patients, including even myself, could potentially be walking around with a deviated septum.
Yeah.
For those of you who don't know what a septum is, it's basically this area of cartilage as well as bone in the back that divides your nose. Deviated means that it's crooked to one side. So for some patients who might need to do something about a deviated septum, usually what that would mean is that they might be complaining of breathing issues,
Right.
maybe worse breathing on the one side. And then when you see an ENT or facial plastic surgeon on exam, they would take a look through the nose and see that this septum, this divider, is more crooked to one side.
Yeah.
If you have the symptoms and the exam findings aligning up,
Then that's a
then
deviation.
as a patient, you might be a candidate to correct this.
Yeah. What I like to do is I have people test themselves out. You could kind of plug your nose and just kind of test. And if you have a little constriction, the difference between the two sides, you may have a deviated septum. I'm not saying you do, but you may. Some people can feel their deviation too. I'm not telling everybody to stick their finger up their nose, but just for this purpose, I am not going to do that for you guys. But that's one thing you could do is stick the finger up the nose and feel your septum, and you can feel if it's a little crooked. You could tell.
Right. I see Dr. Young is making some good comments about
Yes.
use of latera implants, nasal valve collapse. Something else just going along this conversation, if you do have nasal obstruction, it can be due to a number of things. We're talking about septal deviation. Another
Right.
thing can be nasal valve collapse. We have
Right.
what we call internal, external nasal valves. So you think if you see someone or yourself have it kind of pinched here, this and if it collapses, this can be contributing to breathing problems. A lot of times I ask patients if they want to try like a breathe right strip like athletes use, and if that helps, you could benefit from surgery to get more structural support. And then
Yeah.
some patients also have collapse of their actual nostril, which is associated with external valve collapse.
Right. And latera would probably help for both of those. I will say I've used latera. I used a slew of them in my open rhinoplasty cases, and I had patients who said they could still feel the implant past 18 months out, and people didn't like it. So I actually stopped using them. Only because, I do a lot of open rhinoplasty and I'm doing things to help with the valves already anyways. So I just found it was just an extra thing that I was doing and it wasn't adding much more. So I stopped doing latera implants in my cases. Do you do any latera implants, Dr. Ho?
I do not. I think just talking with other surgeons and seeing my mentors as well, in terms of limited results. And again, a lot of times these patients have other anatomic issues that they just need definitive septal rhinoplasty surgery. So.
All right, so
we have a lot of
Flanker
new
Mama
visitors
asked
here, which is
earlier,
great.
she said, my
Questions.
daughter 17 was born with hair lip. She was very self-conscious about it. She comes to me with interest in fixing her nose and lip. I tell her she's perfect the way she is. Can you please give me advice? Hair lip. She was very self-conscious about. I'm trying to understand what the hair lip would be. My understanding is possibly maybe the distance maybe of the upper lip to the nose. I'm not quite sure. It would be great if you could share us a picture. But this is a very open platform. So what I would recommend, Flanker Mama, is I would recommend you send the picture via my email address. It would be info@facesbydrt.com. Or you can go on to our website. We provide virtual consultations. Right now they're waived. And you could go to our website at www.facesbydrt.com and submit a request for an appointment. It will give you a way to schedule, and then we can book you right there, and I can talk to you personally about that.
Okay. I think
All right.
I was wondering if it was cleft lip. I see Dr. Young is mentioning that.
Oh. Maybe the cleft lip? Yeah. That's also a complicated answer. It depends on how big the cleft is. If it's an incomplete or is it a complete cleft, of course, that is something that we would want to take a look at in picture and kind of evaluate. It does require more than just, I think, because it's so complicated of a reconstruction. It's not just going to be something simple. So I will probably just still say we can address that personally, separately off of this platform.
Okay, sounds good.
All right. Dr. Rob asks, do you all bank leftover cartilage in primary rhinoplasty? That's a good question. Dr. Rob.
So, Dr. Rob, if you could guess who one of my mentors is, he routinely does. As I learned in fellowship in Chicago, I do not.
Yeah.
How about you, Kristina?
I do. So I don't know that. So I typically, what I do is I will take out, if there's a deviated septum, and I don't always do a septoplasty because I feel that speeds up the surgery if I don't have to go for septum. And if it's just a valve issue, I will do an auto spreader graft while taking down the bump. So I won't touch the septum to avoid too much trauma to it. I find the least you do in terms of trauma to the nose, the better the outcome, the better the healing, the less the swelling. But if I am going to fix a deviated septum, then I take out I take down the bridge first, and then I take care of the septum. And then when I'm doing the septum, I make sure that I'm just addressing the deviated portion to save as much cartilage first. And it depends on how much cartilage I need. So I plan it all out first before I even get any septal cartilage. I take out the deviated portion, and then I cut the pieces that I want, and then anything that I have left I put back, because sometimes when you have a deviated septum, the cartilage is so wonky, it's not just like slanted, it is going to be like a zigzag shape, so you take the straight pieces and you put back the other parts that you don't want back in. So I bank it back in between the mucosal flaps, and I save it.
Okay. I agree with you. Sorry, because I'm just thinking back to fellowship. But yes, for the septum, I would bank. There's other ways to bank cartilage, for instance, behind the ear.
Yeah.
So
good approach. Yeah. All right. Dr. Young asks, how often do you inject Kenalog for post-op swelling? That's a pretty common.
Yes, Dr. Young, you guessed my mentor correctly. So I think I can start to answer first.
Yeah.
And again, I think we've had a number of visitors, which is great. Again, I'm Tina. I'm a facial plastic surgeon on the East Coast in the Philly area. I'm with Kristina. She practices on the West Coast here, and we're talking about non-surgical versus surgical rhinoplasty. So in terms of Kenalog, usually maybe as soon as 1 month after surgery, if they're
It got
or K40, do a little bit. Also, as Kristina had mentioned earlier, it's good to do taping, manual pressure, some razor sizes as well. The key is to do small amounts of injection, and also to get your patients on board. That follow-up is really critical. I like to counsel patients, especially depending on the thickness of their skin. Sometimes their swelling may flare up, especially in hot weather, salty intake of food. And if there's a flare up in swelling, they can come see me sooner, and we can do a little steroid injection to calm that down.
Yeah. So I usually kind of plan it ahead of time and let them know you may need to get Kenalog. So if they have thick skin, like you were saying, I do tell them you may need Kenalog after surgery. And so we're just kind of put it in their mind, plant it in their mind that they're going to need that. Now, the timing is also important. I don't inject too early because I want to wait for as much of the swelling to go away on its own, because we don't want to expose anything that you don't want to expose, particularly on the bridge of the nose and the radix, because the skin is so thin there. I'm very careful about not over injecting that area for sure. But the tip, you can be pretty judicious with the amount of Kenalog injection, the amount of steroid injection that I do there, but I don't start injecting until at least 6 months out from surgery. And I usually combine it with fluorouracil. I have found that what I do is I do a stair step. So I do more fluorouracil in the beginning than Kenalog to avoid getting dips or depressions in the skin. And then as I see they can tolerate it, I decrease the amount of fluorouracil and increase the amount of Kenalog in terms of that ratio. And then I do it every 6 weeks after that period of time, after the 6-month mark.
Okay.
Until I get to the desired result that I want.
Okay.
So Dr. Young says earliest I do is 6 weeks. That's great. You're a little bit more courageous than me. I'm a little bit shy on that part of doing Kenalog that early. All right, and then did we have any other questions here? I want to say hi to Lauren and their stem cell group. And do we have any other questions here? I think we've gone a pretty long while. Those were really good questions. Hi, Ari.
I see Ari Hyman, another Turing fellow, who's just joined.
That's great. All right, so we just got towards the end of this. I think this was a great session. If people want to have a second session on surgical versus non-surgical rhinoplasty, I'd be happy to host Dr. Ho again to come back for another session. If you guys say yes right now, I just need one yes. We'll do it again. So to close out, I will just say, again, I'm Dr. Kristina Tansavatdi. I'm a facial plastic surgeon in Westlake Village, California. And you can find me at my Instagram channel at Faces by DRT. I'm also on YouTube at Faces by DRT1. I'm also on Twitter and Facebook. What other platforms are there? My goodness, let's throw them all out. I used to have Periscope. Anyways, there's been so many social media platforms, but you could just type in Faces by DRT and you should be able to find me. How about you, Dr. Ho? Thank you, Dr. Young.
Thanks so much again for having me, Kristina. This was great, and thanks for all the questions. Again, I'm Tina Ho, facial plastic surgeon in Philadelphia. Instagram
Thanks, Dr.
at Tina Ho. I also have YouTube and Facebook as well. But yeah, this has been a lot of fun. Great to see surgeons we know asking awesome questions, prospective patients as well. Feel free to send us messages to ask additional questions.
Yes.
This is a lot of fun.
And then the last part I wanted to add is tomorrow I'm going live again, same time, same bat channel at 3 o'clock in the afternoon with Dr. Rob, one of our guests here that just came in and asked some questions. So Dr. Rob will be joining me at 3 o'clock tomorrow, and we're going to be talking about life in the time of coronavirus. Hope you guys can join us, and we'll see you then. Thank you.
Okay.
Bye.
Thanks again, Kristina. Appreciate it.